We've all had rough patches in our lives where we felt down, but in some cases, that feeling of being down is quite persistent. How do we know if we're sad or experiencing depression? Welcome to UT Health San Antonio's Wellbeing Wisdom Podcast, a dose of learning for healthier, happier lives, brought to you by the Office of Human Resources. I am your host, Tiffany Dale, and our topic today is differentiating sadness from depression. We are joined by Dr. David Roberts, an associate professor of psychiatry at UT Health San Antonio's Long School of Medicine. Dr. Roberts specializes in developing and implementing community based behavioral health services, notably through the Transitional Care Clinic and the New Opportunities for Wellness, or NOW, clinic. Dr. Roberts is an expert in training therapists in evidence based counseling techniques and routinely provides clinical training both nationally and internationally. He also is widely published in areas related to social cognition and psychotherapy for serious mental illness and therapist training. Most recently, he developed reflective training, an innovative, cost effective, and scalable method for disseminating effective psychological treatments. Welcome, Dr. Roberts. Thank you for your dedication to improving health outcomes across South Texas and for sharing your well-being wisdom on differentiating sadness from depression.
Thank you. I'm happy to be here.
We are delighted to have you here with us today, Dr. Roberts. So, to kick things off, please tell us a little bit about yourself, your professional journey, and your expertise in treating depression.
Well, thanks so much for having me, Tiffany. I'm really pleased to be here and to have this opportunity to talk with you about depression and what we can do to recognize it and respond to it. So, as you mentioned in your introduction, I'm a clinical psychologist. I've been in the field for about 20 years, most of that time here at UT Health in San Antonio. My focus, it's always been first on sort of developing psychotherapy and counseling approaches for all sorts of mental health concerns. My second sort of focus has been training people to use these approaches and then helping to spread useful approaches to be used in different areas. As you mentioned, my work at UT Health has primarily been in the Transitional Care Clinic, or TCC, and the NOW Clinic. So that's really sort of the crucible for my development of expertise in treating depression. Between 2014 and 2024, I was the director of the Transitional Care Clinic, and the mission of this clinic is to receive referrals from area hospital psychiatric inpatient units and also triage clients or patients who present to emergency departments in area hospitals with a behavioral health or a mental health concern, but who are not admitted into the psychiatry unit and therefore are triaged out. Now, many of the people who either show up in the emergency department or are treated on the inpatient psychiatry unit do not already have an existing outpatient mental health providing team. And so, and because of all the pressures of the economy and insurance, it can be hard for these folks to get access to care so that when they're discharged from the hospital, can they have a soft landing? Can they have the supports that they need in place? So the Transitional Care Clinic was developed in 2012 with the mission of receiving those hospital referrals and providing 3 to 6 months of what we call transitional care. And after that, we refer these folks out into the community if they would like for ongoing depression, anxiety, bipolar disorder, schizophrenia treatment, those types of things. So really, this is the context in which meeting clients who have recently gone to the hospital because of severe depression and are now trying to sort of get back on their feet in the community. This is really where I've developed my greatest expertise in working with depression. And then I'll just mention most recently, as you pointed to in your introduction, I've been doing more and more very exciting work on seeing what the limits are of how many members of our community can really provide the types of counseling and psychological interventions that historically have been reserved for licensed professionals. And more we're discovering that especially depression is a condition that many different groups of people can be helpful in treating, including friends, family, church leaders, other community members. So that gives you a little bit of a taste of where my experience in working with depression comes from.
That's great. And I really love that y'all are finding a place for the interim when people don't have that dedicated provider to help them. As you said, it's a soft landing to help them through over the next 3 to 6 months. So that's really good to hear that that's being offered for our community.
Yeah. Yeah. I sort of take a lot of pride in it. It's something that I've learned in my time here that kind of getting out of the what sometimes people call the ivory tower of research on treatment interventions and spending more time actually with clients, with patients, delivering interventions and seeing the obstacles and opportunities at the community level. That's really kind of stolen my heart. And that's where I spend more of my time now.
That's great. So you had mentioned that, there is anxiety and depression and a lot that there is treatment for. So let's just start with the first portion, which what exactly is depression?
Yeah, it's interesting with that question because I think it's one of these terms that is familiar to many of us and has been in common culture for a long time. I think many of us feel like we understand what depression is more than we might understand something like schizophrenia, for example, or multiple personality disorder, which is now called dissociative identity disorder. Depression seems more kind of graspable because of its link with run-of-the-mill sadness. Most of us have experiences with sadness. And if we don't have experience with the type of sadness that maybe looks like depression, we at least have experience with grief and loss. And so there are elements of depression that are very familiar to us. The main features of depression then are sadness, also loss of interest or pleasure in activities that you used to enjoy. And that can kind of cultivate this sense of nothing's really worth it. I don't really think that getting out of bed is going to make anything better or make me feel better. So there's a sort of a sense of hopelessness or a sense that the future is not going to hold anything useful. So it's already been lost. This leads to diminished motivation for activity overall, diminished social engagement, and often it's accompanied by a negative view of oneself. I think it's important also to think to sort of point out that in the last 50 to 60 years, psychiatry and psychology has gone a long way in terms of defining depression in a way that different treatment providers can talk to each other and feel that we're actually describing the same thing. I can say to a doctor at another hospital, Mr. So-and-so is suffering with depression. And that doctor will know exactly what I'm referring to. It wasn't really that way 100 years ago. People in different regions had different definitions. So that's been very helpful. At the same time, what it has done necessarily is sort of simplified the way we talk about depression into a few core symptoms or core domains. Again, that can be very useful. And anybody can go on the internet and say, what are the DSM criteria for depression? The DSM stands for the Diagnostic and Statistical Manual of Mental Disorders. It sometimes gets called the Bible of psychiatry. And that's where you can access a definition of depression and think, does this apply to me or does it not? But don't hold that as the only way to understand depression. There's a lot of things that fall between the cracks in that definition, very personal, subjective aspects of depression that you might not recognize in those, but that you feel in yourself. And that's why having a professional or somebody who has experience working with depression can sometimes be helpful.
Okay, so it can be, hard for us to see individually, as you said. And you did mention that we all get sad once in a while. So if we're in a place, how would we know if we actually just have what some people would call a case of the blues, or if we're actually experiencing depression?
Yeah, right. That is such a key question. And I think most sort of experts in this area would say the truth is that we cannot cleave nature at its joints and make a bright line distinction and say there is something that is called depression that is in this bucket, and then everything else is not depression. More and more, everyone agrees that it's a continuum, it's a spectrum. that we are sort of always, all of us, at some point along the spectrum between feeling what we could call euthymic, which means sort of normal, or feeling like you have elevated mood, or feeling like you have depressed mood. But having said that, we do need to be able to say at what point along this continuum do we say, here, this is clinical concern. It's reached a level of what you sometimes hear called clinical depression. And so the main way that care providers try to draw that bright line or make that distinction is in terms of sort of separating sadness from depression in change in two main areas. So the first area is your daily functioning, or what we could think of as your behavior. This is really a question of your sort of, if you look at the last 3 to 6 months, has there been a big change in decreased engagement with the world, more time spent alone, more time spent in bed, not answering the phone, not following up, and not taking care of oneself in terms of things like hygiene? There's also associated with that decreased, even when you are among other people, a decreased verbalization, decreased thought content, and decreased talking. All of those are sort of objective behaviors that we can look at and that you can ask friends or family member if you're comfortable with it and say, has there been a change in my behavior in these ways over the past 3 to 6 months? That's the first one. The second one is your level of distress. Okay, so the first one is there some sort of functional impairment or dysfunction in your behavior? The second one is there a significant change in your level of distress? So you can kind of think of distress like, sometimes you go to your primary care doctor and you have some sort of pain or discomfort, and they'll pull out a 1 to 10 scale that has a frowny face on it and a straight mouth face on it, and then at the high end it has a smiley face. And they'll say, where is your, or vice versa, actually. And they'll say, where is your pain on a scale from 1 to 10? It's sort of like that. You can think of, instead of your physical pain, think of your mental or emotional distress from 1 to 10. And has that distress level taken a big leap? So obviously, to think about what that distress means, you're really looking inside and being subjective about it. But we're talking about feelings of sadness. And more broadly, it's often useful to think of it as a sense of loss, a sense that if you think of it on a sort of temporal dimension, that it is already gone. What might have been, what I would have hoped for myself, for the world, for my family, hope is lost that it could be better in the future. And so very often, and these concepts can feel kind of slippery if you haven't personally experienced depression, but there's a sense of foreshortened future, a sense it's all lost. And so when I try to see myself in the future, I don't really see stuff. When we're doing well in life, often we spend a lot of time looking forward to things. And we even boost ourselves up and kind of foster happiness for ourselves by looking forward to things that we have upcoming in the future. Maybe I'm looking forward to going home and seeing my family at the end of the day. Maybe we have a vacation planned. Depression tends to sort of cut that off, and you try to look for the future, and all you see is blackness or darkness. And so that cultivates a sense of sadness. And at its worst, that feeling can lead into a sense of there's no future for me, and that means death. And we call this suicidal ideation. And we get sometimes what's called morbid rumination, like I can't stop thinking about death in general, or the sad fact of death in the world. And then at its worst, it gets more and more self-focused, and then that can come along with feelings of self-criticism, guilt, and shame as depression gets worse.
So that lack of hope can be so overwhelming. And that would tie in to what you were explaining earlier of, if I get up out of bed, it's not going to make any difference. So not wanting to get out of bed and that lack of hope would be tied to one another as well.
That's right. Exactly. There's that sense of it's not worth it. Nothing good can happen anyway. And then the other piece that we were sort of touched on at the end is a sense of what does that mean about me? What is that, the sense of hopelessness and no future? What does that say about me? And if you have depression, there's a tendency toward saying it means that I'm a bad person, that I'm a worthless person, that I'm an unlovable person.
You had mentioned anxiety earlier, and we'll sometimes hear those terms, anxiety and depression, used interchangeably. Are they actually the same conditions?
That's a great question, Tiffany. And I'm smiling because I actually, in just a few hours, I'm going to hold my weekly depression and anxiety group. It's a counseling group that I do every week. And no, they're not the same condition, but they travel together all the time. They're sort of like complementary partners in causing distress and dysfunction in humans' lives. And so I think a way to think about the relationship with depression and anxiety. You remember, Tiffany, a few minutes ago, I was saying that depression has this quality of sort of being a backward-looking negative feeling. All
Yes.
is lost. There is no future. You can sort of contrast that with anxiety, which like depression, is a feeling of distress that can be, high distress or low distress, and associated behavioral dysfunction that can also be high dysfunction or low dysfunction. But these things look a little different in anxiety. Whereas depression is a backward looking feeling, anxiety is a forward looking feeling. So anxiety is more a sense of, oh no, what's going to befall me in the future? Oh no, I see a catastrophe coming. Oh no, I have to go talk to my boss. I'm sure that she's going to give me a bad review. Oh no, I haven't heard from my son in 2 hours. Perhaps something horrible has happened. So, this forward looking sense within anxiety, and it kind of signals you to say, you better problem solve, you better do something, you better take care of this or else. And so that means anxiety creates a sort of an activating feeling in the person. It's a negative, difficult feeling, but it's an activated feeling. You have a rapid heart rate, sometimes sweaty palm. Your mind can be jumping around, racing, and unfortunately, it can mean that you don't solve any of the problems you see because you're flitting from one problem to the next. Whereas in depression, there's a sense of there's no hope. So the way these two can work in tandem, often you can picture somebody where it sort of starts with anxiety, and the anxiety becomes increasingly crippling for that person to where, for example, they're concerned if they leave the house, something horrible could happen. So they isolate themselves increasingly. And as this happens more and more, they start saying, it's never going to change. It's always going to be this way where I'm too anxious and I can't leave my house. There's no future for me. And that persistent anxiety can cause depression, and then it can come in a cycle, and they can start cycling back and forth. So that gives a little bit of a picture of how they're related.
It does. And it's a very vivid picture. You had mentioned that with anxiety, some of the things that might occur are the sweaty palms or a rapid heart rate. What about depression? How can it impact us physically?
That's really a good question. And so, one way we can think about how these things affect us physically is in terms of our behavior, which I've already talked about some in depression, and also our physiology. So when we were talking about anxiety, I was emphasizing physiology, the rapid heart rate, the sweaty palms, even the racing thoughts. The racingness of thoughts is a sort of a physiological agitation or arousal feeling. Your body is keyed up. So in depression, it's the opposite. I had said in depression that there's behavioral withdrawal. There's on a cognitive level, then we have the same thing. Whereas anxiety is a ramping up, depression is a ramping down. So we get a diminished number of thoughts coming into the person's mind. Sometimes you interact with a person who has depression and they don't say very much. Often that is because there's not very much coming to their mind. The thought process is literally slowed down. The ability for the person to link words to thoughts and produce the words is also diminished or slowed down. The person's motivation in all sorts of domains is diminished. Their sense, as we mentioned earlier, of there will be a reward if I do this. Their reward system says, nope, it's kind of offline. There's not going to be any reward if you do this. So it's a great deal of diminished, of sort of behavioral diminishment, hygiene as well. You'll sometimes see increased slumber, but you'll sometimes see decreased slumber. Similarly, you'll sometimes see increased appetite or eating. Other times you'll see decreased appetite or eating. So those are the main sort of physical physical and bodily effects of depression.
And that can be so encompassing. Just in general, what do people get wrong about depression?
That's I think a very important question that you're asking there, Tiffany. And it's an interesting one to think about. I think, let's see. I think what I would want to bring into this conversation is how we, those of us who are not specialists, not professionals in mental health or behavioral health, how we respond to depression. I think let's take a look at that. Let's take a look at our reactions to depression. And in particular, I want to bring up suicidal thoughts and feelings. If there's somebody in your life, in your sphere that has suicidal thoughts. So it's important, I think, to keep in mind that suicidal thoughts are not uncommon. This is something I've really come to understand clearly working in my time at the transitional care clinic. We routinely are working with people who are walking around with suicidal thoughts. It's a very common thing. 1 in 20 people, look around you, 1 in 20 people has suicidal thoughts. Okay. So
Wow.
yeah, so keeping that in mind and remembering this is not some extreme sort of outgroup that is so far away from normal experience. It's really not that uncommon a thing. And what that means is when we encounter it, we can encounter it in a bit of a more normalizing way. Understanding this is just part of this other person's daily and weekly experience is managing this the way perhaps I manage my bad knee, or I manage my diabetes, or I manage my heart condition. Managing suicidal thoughts is a really common thing, and really something that as care providers, that's where the action is for helping somebody with suicidal thoughts and feelings. I think there's maybe a way of thinking about it is, oh my goodness, if I hear that somebody has suicidal thoughts, we need to get them to the hospital. And that is absolutely true if that person is at immediate risk of harming themselves because of these suicidal thoughts. But the nature of hospital treatment these days is very different from the way it used to be. And for good and for bad, hospital stays tend to be quite short in the nature of maybe 3 days to 2 weeks. And it's just not enough time to do a sort of treatment that would really diminish the suicidal thoughts significantly or really help with the depression in a long-term way. Hospitalization is more keeping the person safe for a few days and getting them to where they're not acutely suicidal. But the real work of working with suicide and suicidal thoughts is out in the community and supporting the person who's having these thoughts. So we might, there's sort of links into this misconception that some of us, I think, have in our minds that I don't want to talk with the person about their suicidal thoughts because I might give them the idea, or this person seems very depressed. I don't want to ask if they're suicidal because then that might give them the idea that they're going to go try to take their lives. That's just not true. That really doesn't happen. So don't worry for that reason about asking somebody if they're feeling suicidal. Now, it's perfectly understandable if you feel hesitant to bring up the topic because it's such a heavy and personal topic. That makes a lot of sense. But don't avoid it because you think you might sort of plant the idea. And then to sort of finish this little soliloquy I'm giving about suicide is more and more, we were talking earlier, Tiffany, about how I am increasingly working with groups to equip community members to provide psychological interventions. One of the main ways we do that is equipping people to respond when they see somebody who's having suicidal feelings. And more, any of us in the community, it's very much like CPR. You don't have to be a cardiologist to administer CPR. You don't have to be a psychiatrist to help somebody who's having suicidal thoughts. So I'd really want to kind of emphasize that.
So, what would, let's say, me as a layperson in the community, and I do find someone who has suicidal thoughts, how would I be able to help them right there in the moment?
Well, I would say two things. So one, you can learn a quick and easy procedure to help that person. There are a number of these things. For example, one that we use here at UT Health that's used throughout the Department of Psychiatry here and also in other practices. It's called crisis response planning. And it's a form of what in this field we refer to as suicide risk assessment and safety planning. And so this is something that, again, historically was reserved for professionals, but now is widely available through a 1 or 2 hour training and a little bit of practice to anybody in the community who wants it. I'd be happy to link anybody up who's listening to this with that training because we provide it through UT Health. So that's one option, is educating yourself on a quick standardized way to respond with some useful prompts or some useful statements. And you can either do a more formal planning thing, or there are sort of mental health first aid type approaches that just sort of gives you a framework in which to have a supportive conversation with that person. The next thing I want to sort of emphasize is, let's say, and this is going to be true for most people, you haven't taken any sort of training on how to do this. I would say keep this in mind, that most people who are depressed and feeling suicidal are harboring a sense of being disconnected from the rest of the world, disconnected from the rest of humanity. And that the best thing for so many folks in that situation is just to feel a sense of human connection. Just to be, because remember, the sense of hopelessness we've been talking about, it very often includes a sense of, who am I kidding? I'm alone on an island, dark by myself. If we can create for that person a sense of caring coming from another person, a sense of connectedness, or just listening with true intent to try to help, that's fabulous. That's really, it's hard to do better. We mental health professionals can hardly do better than that. So I would say sort of lean in, sort of be courageous and lean into that supportive, empathic conversation.
That's great to know that just we untrained can help even before we even go to a class. So providing that support, that is really helpful to know. What would someone need to tell their doctor if they might be experiencing some of these symptoms or feelings that you've talked about earlier? What would be a good way to bring it up to their doctor?
Again, really good question. One thing that happens a lot is that people, this happens to me all the time, all the time. In fact, I've been meaning to call my PCP back because I was supposed to get my shingles vaccine and I forgot because I got starstruck in my doctor's office, or I don't know, I got distracted or I got and this happens to all of us. We kind of, and then especially if it's something like bringing up depression or suicidal thoughts, that, you know, we may feel shame, we may feel embarrassment, especially if we're having depression. We may feel that it means something bad about us to bring it up. So the first thing is just having sort of the courage to bring it up with your provider, recognizing it makes sense if you're feeling uncomfortable about bringing it up. And one way to sometimes make it easier is to take a few notes for yourself on an index card. Make sure I want to say this and I want to say this and I want to say this, and bring that index card in. And sometimes I work with clients who say, I just had to hand the card to the physician because I wasn't able to sort of say it. So that's great. That's a fine thing to do. You can have a friend or family member help you work out a little index card that you can bring in there. And then keep this in mind. If you're going to be talking with, let's say, a primary care doctor. So primary care doctors, this is not their bread and butter, psychiatry, diagnosis of depression, but it's absolutely something within their purview. So what they're going to be doing is looking to the DSM that I mentioned earlier, the formal medical definition of depression. And so it might sound funny. I'm like, oh, go on the internet and do this. But it really is not a bad idea to look up the definition, the DSM, Diagnostic and Statistical Manual criteria for depression, and ask yourself, which of these do I meet? Think about what the real true answer is to each of those questions, to each of those criteria. So you can sort of have it in mind. You can do a little preliminary, does this seem to characterize what I'm going through? And then go into the doctor and share that. So putting a little bit of thought about those categories, knowing that that's how your doctor is going to try to diagnose it. And then another thing to sort of keep in mind is, what would be your preference for treatment? Having maybe a little bit of a sense of, if your doctor recommends treatment, how do you feel about that? And if your doctor provides some treatment options, which ones would be acceptable to you and which ones would not? Again, in terms of the relationship with the doctor and how it can sometimes feel intimidating, it really needs to be your decision about treatment, and preparing yourself for that before you go in.
So along those lines, what treatments are available to individuals who are suffering from depression, and is one treatment better than another?
Yeah, that's a crucial question, and something people should want to know. And really, it's good news. It's really good news. There are more treatment options than ever, and we know more about them than ever. So sort of I would say three main categories. So there's counseling or psychotherapy, and I'll kind of use those terms interchangeably. There's medication, sort of typical medications, things like Prozac that people will have heard of. And then there's what we call interventional psychiatry, and that's usually used when the therapy and the medications have not worked, and you need to try something stronger or different. Okay, so I'll go into just a little bit more detail with each of these. So the first thing to know is that really, if you look at the main two, therapy and medication, that they both work. They both work pretty well, and they both work relatively equally well. A little difference between, and so what that means is that your choice is what's most important. You know, that you as the patient really should, and patients very often have clear preferences when it comes to therapy or medication. I would say, in thinking it through, some things to keep in mind is a lot of people have attitudes, for example, about medication. Like I would prefer to try a lifestyle change before I try medication, right? Prefer to try talk therapy or behavioral intervention before I do medication, and that's fine. You can totally do that. One of the upsides of going with counseling or psychotherapy first or instead of medicine is that it tends to have better long-term sticking power as a treatment. And the reason for that is the way psychotherapy works is it sort of teaches you, the client, how to be your own therapist, how to self-manage depression. And whereas medication is obviously you don't learn how to self-manage it. And medication has its own advantage, which is it often can work more quickly and get a quicker effect than psychotherapy can. But with medications, it can diminish over time. I think that I should say with medications also, and I'm not a psychiatrist, so I don't prescribe medications. And so you really have to talk to a physician or a nurse practitioner about this to get real detail about it. But I am, comfortable sharing that it is often that there are different types of medications that you can try and different classes that work in slightly different ways in terms of the neurotransmitters in your brain. And it really is the case that there are differences between people in which medication is the best for them. So for good and for bad, what it means is that when you elect to try medication for depression, it will often be a process of trying one out, seeing if it works. And if it works, great. But if it doesn't work, you might have to switch and try another one. So there can be a bit of a process of sort of try and, try and fail and then try another one. So those are sort of therapy and medication. And then the interventional psychiatry stuff. This is when you've tried two or three different medications and psychotherapies, and those haven't worked. Then you can use one of these things. There's several categories. For example, Spravato is the name of a medication that you come into the clinic. And happily, we actually, UT Health Psychiatry is quite cutting edge in this way. We really offer all of these options I'm going to be talking about: Spravato, ketamine, transcranial magnetic stimulation. All of these are really cutting edge treatments for depression that have shown impressive effects in the last decade, and now are just getting into regular use in clinical settings. Spravato is a nasal spray. You come into the clinic to do it, and you can start feeling effects in as few as several hours or several days, whereas traditional medications sometimes can take several weeks to have an effect. And then there's ketamine, and then there's transcranial magnetic stimulation, which is actually a sort of like a brain scan type of a situation where you go into a place and they put nodes on your head, and it gives you a magnetic sort of I shouldn't even be talking about this. It's a magnetic stimulation treatment that is just now emerging as an effective treatment for some people who have depression, and it's available. And then last, you may be aware, one of the surprising new developments in recent years is things like psilocybin, which is traditionally was mushrooms that sort of people would eat recreationally back in the 1960s.
Yes.
But
Yes.
now increasingly there's surprising research showing really strong effect sizes for certain kinds of depression and other conditions. That's still an emerging area, but it's looking very promising.
Those are great, and that they are cutting edge and that we're able to offer that here with UT Health. I'm sure brings a lot of comfort to a lot of people, and it's good to know that we have that to offer.
Absolutely.
This has been an incredibly enlightening conversation, Dr. Roberts. So thank you so very much for joining us today, being our podcast guest, and making lives better by sharing your well-being wisdom with us.
Well, thank you so much for having me, Tiffany, and I really appreciate y'all having this platform to get this type of information out to the community.
Thank you. Until next time, everyone, join us when we will be discussing getting outside. Until then, take good care.